Okay, good morning. Today we're going to do a teach pack on the disorders affecting the kidneys, the urinary tract, and of course the reproductive organs. In the field of medicine and nursing, we have to be fully aware of the role played by the kidney and the other organs that are part of what we call urinary tract, right? Why? Because when you deal with, one of the things that you always do is making sure that the patient has adequate kidney function, right? So can anybody tell me what is the function of your kidney? Anyone? To filter what?
The blood.
The blood, okay? What needs to be filtered from the blood? Waste. So you know what the word waste means. Waste means it's something that we do not need, and therefore we need to excrete it from our body, our body. So like when you make poo-poo, right? Is your feces waste? Yes, it is. What about when you make wee-wee? During the act of urination or micturition or voiding, is that also a means upon which you can get rid of waste? Yes, it is, right? Okay. And what else? So aside from filtering the waste, which is essentially your what are these wastes that we are referring to? Can you help me tell me? Urea, creatinine, and then what? Uric acid. Now these waste products are known to be nitrogenous waste. So obviously they contain the element called nitrogen. Now, we need to understand, how is this possible? How can we be able to create this nitrogenous waste? They are brought about by the breakdown of what particular food substance? Is it fats, carbohydrates, or proteins? Proteins, very good. Okay? From the breakdown of proteins, right? So if you remember, the building blocks of proteins are amino acids, and do they contain nitrogen? They do, right? The idea therefore is that these waste products are brought about by the breakdown of proteins, and when they are produced, we need to get rid of them because we do not need them. We need to excrete them. Does that make sense? Okay? Therefore, the question now is, because they are waste products, we need to excrete them. How important is to know the anatomy and physiology of the kidney? Very simple. I will jump the clock and I say, or the topic by saying, if the kidney fails, therefore what happens? Will the kidney be able to filter the blood? Will the kidney be able to filter the blood and remove the waste from the blood and allow the waste to go out in the urine? Not anymore. Okay? So you might be wondering, what has it got to do with protein? So what kind of diet do you think we should recommend these patients? High in protein or low in protein if they go into renal failure, especially in chronic renal failure patients? What should we do? Are we going to modify the diet? High in protein or low in protein? What?
Low.
Why low?
Because the body can't break down the protein. The waste from the protein can't be excreted, so if they have too much, there's going to be more waste.
Okay, so you're saying therefore, if you give them a high protein diet, then obviously you have produced more what? Waste. And therefore, if there are more waste, how can the failing or failed kidney be able to perform its role when you have too much proteins to get rid of, right? Or nitrogenous waste to get rid of. You're absolutely right. The analogy I'd like to give to you is this, like a janitor. What does a janitor do? Clean the rooms of this building, right? Okay. On an average day, the janitor is able to clean, let's say, 10 rooms per day. Okay? 10 rooms per day. Now, when he's normal, he's not sick, he's healthy. When he is sick, for example, next week he would come in, but even though he's sick, he's just a cough, cold, but he still wants to go to work. Now, what's the most logical thing to do? Give him 10 more additional rooms, so from 20, let him clean 20 rooms, or just maintain the 10 rooms, or probably even lower the 10 to maybe 5. Okay? So maybe you want to lower it from 10 rooms to 5 rooms, right? Because he's sick. Or maybe you could actually let him go home, but of course that cannot happen in the kidney. The kidney will always be on standby, right, and work. So obviously that answer would be a low protein diet. Do you understand? Okay. Does that make sense to you? Okay. Because whether you like it or not, although the doctor decides what kind of diet, or the doctor will be the one to order in the chart what to do, the idea is that when you are in a nursing profession like you need to know why. That is what we mean by the word smart, critical thinking nurses. Gone are the days when nurses are just going to just simply follow orders. You have to critically think, why was this ordered by Dr. Gama? How come a low protein diet? Okay? Is that clear? So now going back to this, we said the kidney, what does the kidney do? Filter what? The blood, right? And for you to filter the blood, there has to be a filter in the kidney, right? And we're going to that, right? Now, for the kidney to filter the blood, then the blood has to go to the kidney or enter the kidney. Therefore, my question to you is, what is the name of that blood vessel that brings blood to the kidney? You're so smart. Of course. Right? So you have 2 kidneys. Observe the right kidney is lower than the left. How come the right kidney is lower? The liver on the right side will displace it downwards. So these renal arteries carry oxygenated blood, but would it carry also the waste? Yes. And where did this renal artery come from? Which one? Abdominal aorta or abdominal aorta? Of course. And you know what happens? The abdominal aorta came from the thoracic. It pierces the diaphragm here. Thoracic, descending, ascending, arch like this. And then of course it came from what? The left ventricle of the heart. So every time the heart pumps blood, blood is from the left ventricle of the heart, ascending aorta, arch, descending, and apparently it goes down here into the thoracic, abdominal, and then it goes into the renal artery. So it carries oxygen and what? This waste. So the kidney will filter the blood, remove the waste, and where does the waste go? Into the ureter, right? And into the urinary bladder, and into the urethra, and out. Do you understand? So the idea, therefore, is that it will always be anatomy and physiology, it will always be the foundation of medicine and nursing. Whatever we do, you can only become a smart nurse or medical doctor if you know your anatomy and physiology. Because if you know what is normal, then you know what's going to be abnormal. Now, what happens? What is the name of the blood vessel that brings blood away from the kidney? Anyone? Yes? The renal vein. Okay? So let's have a renal vein here. Let's get moving to the other side. And where does the renal vein go? What freeway? We travel here in California, we take the freeways, right? 5 freeway, 5 north, 5 south, 405 north, 405 south. So which one would be the 5 north freeway?
Inferior vena cava.
Okay, inferior vena cava. And why is it blue? Because it is venous blood. And the venous blood obviously contains blood rich in carbon dioxide, which came from the kidney. And where does the inferior vena cava bring the blood to?
The right.
Okay, back to the heart. As you can clearly see, therefore, what came from the heart goes to the kidney. What came from the kidney goes back to the heart. And you know what happens in the heart, in the right atrium, right ventricle to the lung? What do we do with the carbon dioxide here? Exhale, right, in the lung. And then the blood goes back from the lung to the left side of the heart via the pulmonary veins, right? It now carries oxygenated blood. So remember the word circulate, the word circle, circulate. Every time the blood circulates in the kidney, The kidney performs an important function, which is to what? Clean the blood. He's the janitor of the blood that removes all the waste. Now the question is are all this waste removed completely? In other words, if you were to measure the levels of urea in the blood, which is called BUN, what would be the normal levels? 8 to what?
25.
Okay? So apparently, there's still what? Remaining urea. It does not really completely be removed. Right? What about the creatinine? The serum creatinine. 0.6 to what? 1.5. Okay, so let me make you understand why is it that you need to memorize this, because in your board exams you do not get the normal knowledge. You have to know them by heart, memorize them. Okay? So when will it be elevated for BN and if it's greater than what? 25. When will it be elevated when it's above what? For creatinine when it's above what? 1.5. You understand? Now, question now is this. Again, so that you will understand the clinical correlation. Why is it that I need to know these things? Very simple. When the patient is having a kidney failure, when the kidney is failing, when the blood that goes here is being filtered and the kidney is not able to properly filter the blood, what happens to the urea and the creatinine? Will they be able to go out into the urine?
They increase.
Where do they go? They still remain where? In the blood. That's why in patients with renal failure, you would expect this to become what? Greater than 25, greater than 1.5. Does that make sense? Okay? Therefore, we call this diagnostic test as what? Kidney or renal function what? Tests. Is that the first commonly done one, right? So, but the question is, Dr. Gambo, how do I know that this patient is probably suffering from kidney failure? What is it that will make you think, hey, you know what? We have a patient not having a normal kidney function. What would think will make you think that there is probably kidney function? What is it that you have to measure? The urine output. Very good. What's your name? Javier. What is considered a normal urine output? Because remember, the bottom line is that the kidney will form the urine, right? Do you know? How many ml of urine would you expect a normal person to have every 1 hour? Javier? Above 30 ml. 30 or more, right? Okay? In other words, if it is less than 30 ml per hour of urine, what is the term we use? Yes, anyone? Oliguria. It comes from the root word oligo, which means what? Scanty or little. And urea means urine. One of the things that we normally do is we insert a what? An indwelling catheter into the urethra. The catheter is attached to a uro bag, and there are calibrations for the amount of urine coming out. The moment the urine output is less than 30 ml, will you be alarmed? Will you call the doctor? So you call doctor. Okay, Dr. Gamo, from 6 to 7 a.m. this morning, the urine output of the patient is only 20 ml. Is that below 30 ml? Yes. Is the patient oliguric? Yes. So now, I tell the nurse, I ask questions. Is this patient having diarrhea? Is this patient dehydrated? Blah, blah, blah. Is he bleeding or something? So I need to know why is this patient oliguric. But one of the things that we normally order in the chart is the diagnostic test. One of them is called BUN and creatinine, correct? Okay. Now, if I say, okay, start BUN, right? Okay. What specimen are you going to send? Yes. You. What specimen are you going to send to the lab? Urine specimen. Why?
Because that's where you can find if it's elevated, the waste.
Okay, what's your name?
Cyrus.
I want to ask you this question. Do you know what the B in the BUN stands for?
Blood.
What?
Blood.
Blood. So now, would you like to reconsider your answer? Are you going to send blood or urine specimens to check for the BUN levels?
So blood.
You realize what I'm trying to tell you, right? Before we answer, we have to, I'm not saying you did not think, but you blurted out urine. But now you know the correct answer, right? That will make you pass the board exam to pay your student loans, right? Every answer is important. Every mistake you make could either make you pass or what? Fail. You know that? In 2002, for 8 years, I was doing a review class for nurses. Some of these students that come to me, they think of me as their savior because, oh, I heard about you. You talk about anatomy and physiology in your review for the nursing NCLEX review. And many times, the reason why they do not do well is because why? Their anatomy and physiology background is what? Very important. These people have taken the nursing board exam 10 times. And they keep on what? Failing. Because all they do is they buy a reviewer with sample questions, and what they do is just simply memorize the answer without understanding. You have to understand. Why did we order the BUN and what specimen are we going to send? Is that crucial? Is that important? Yes. Because what happens now if you send the urine specimen, I order the BUN level, and after 1 hour I call the nurse, what's the result of the BUN? And there's silence on the other end of the line. I'm sorry, Dr. Camo, I sent the wrong specimen. And how's the patient? The patient is dead. I'm just joking, of course. Why? Because he went into... So a delay in anything we do can mean a lot of things, right? It could make the patient worse, or the patient could die. Of course, they will not die within 1 hour just because you sent the wrong specimen. But I'm trying to exaggerate the point that we have to be always smart. We have to realize that we can't afford to make mistakes if possible. So if I order a stat BUN, what specimen? Blood, because the B stands for what? Give me a B, which means blood, not a U, remember? B, B, L, O, O, D, D. Blood. What about serum creatinine? What specimen? I hope you understand. But, oh, that's so easy, Dr. Gamo. But when you're given the situation, you ask point blank, what specimen? I would say many people would say urine. The first thing that comes into their mind, not realizing that the B stands for what?
Blood.
And the serum stands for what? Do you understand? Okay? Now, it is therefore necessary we understand what is it that really filters the blood. Remember the word nephron? Right? Let's briefly review the parts of a nephron, right? We have the Bowman's capsule here, right? Then the proximal convoluted what? Tubule, PCT, the loop of Henle, and this DCT, distal convoluted tubule, and eventually the collecting ducts. In front of these would be the filter called the glomerulus, right? And what is a glomerulus, my dear? Capillaries. And exactly what is a capillary? A capillary is a what? A blood vessel, the smallest blood vessel, okay? So what is found inside this blood vessel? Of course, don't you love anatomy? Blood, okay? And where did this come from? From the glomerulus? It came from the afferent arterial, capillaries, efferent arterial, and then eventually where? To the peritubular capillaries. Correct? So you have glomerular capillaries, peritubular capillaries, then series of veins, then eventually what? The renal vein, right? Okay? And the renal vein, as we said, goes back to what? Inferior vena cava and then to the right atrium of the heart. But on the other hand, the afferent arteriole came from where? A series of arteries, interlobular, arteriolobar arteries, but ultimately it came from the renal what? Artery, and this artery came from the abdominal aorta, right? And the aorta came from where? The left ventricle of the heart. So from the heart, it goes back to the heart. And of course it passes through the lung and it goes back to the left side of the heart. In other words, every time it goes to the kidney, the glomerular capillaries will filter the blood. Aside from the glomerular capillaries, the Goldman's capsule also plays a role in the filtering of the blood. Now, how many of you here were my former students in anatomy? Yes, you were. Yes, you were. Okay? Do you remember what did I use as an analogy to describe the word filter? Filtration performed by the glomerular capillaries. Do you remember? What was it that I tried to simplify the discussion by coming up with a tool that we use in the kitchen that is important in the process of filtration? Yes?
A strainer.
A strainer. Were you my former student? How come you know?
Because I watched your videos on.
Oh my God, you watched my video. Which video? In anatomy or path? And path. I use the same analogy? Okay. You watched my video. Which one? The one last night or the one the previous night?
There's one from like a few weeks ago.
2 months ago. Like Diana wanted the new one. I said, okay. Ms. Jeffa said, Tatragama, can you do the one last Tuesday night? Okay. To upload it on YouTube, it takes time. Sometimes it takes hours. So I was about to sleep last night. Okay, but remember, I had the same teach back 2 months ago and maybe 4 months ago. So it's the same thing that I talk about. But sometimes there might be things that I might discuss in detail here and not in the past. But it's okay. So for those of you who go to the kitchen and cook, how many of you cook here? Okay, me, I only eat, I don't cook. My wife doesn't cook too, okay? We love to eat. The strainer. What does a strainer have? What? What kind of hose? Big or small? Small or small? Strainer. Imagine all the, I was about to say, imagine all the glass that's empty. Think of this as an empty glass. Do you see the empty glass? Do you see it? Virtual empty glass. I put an orange fruit here. I squeeze the orange fruit. What will go into the empty glass? Orange juice from the orange fruit. Isn't that amazing? The orange juice came from the orange fruit. That orange juice represents the urine together with the waste. Urea, creatinine. Well, why is it that the urea was able to go through? Because the urea is what? Small or small? Was it able to fit through the hole? Now these holes are called pores, P-O-R-E-S. Creatinine, uric acid. Now what remained on top here? What is found here in terms of the orange fruit? The pulp, precisely. The seed, the pulp. Why is it the pulp and the seed did not go through? Because they were what?
Too big.
Too big to go through the small holes. Only the urea and the creatinine went through together with the urine, the juice. So, what would that represent? The pulp and seed represents what, Ms. Javier? The red blood cell. Because why? The red blood cell is big and the pores are small. And not only that, every time the red blood cell goes here, it goes through because it's too big, continues to remain in the blood vessels, while the urea and the creatinine and the uric acid will go through to be part of the initial glomerular filtrate. Do you understand? So I might just again jump the topic and say, what do you think happens in post-streptococcal glomerulonephritis? Like me, for example, if you have a sore throat, 2 weeks later, you complain that the urine is red instead of pale yellow to amber. What is now in the urine?
Red blood cells.
Red blood cells called hematuria. Why would that be?
Pores get
Because when you say glomerulonephritis, what happened? This gets inflamed. And what is the mechanism of pathology there? To study, yes?
Proteins can get in the pores.
So both, if you have glomerulonephritis, goes post-streptococcal because you had a strep infection, 1 week later, remember, you develop what? Antibodies against the streptococcal bacteria, against the bacteria, but at the same time, it can also cause what? Damage and inflammation of the glomerulus. What happens to the holes? Huh? Bigger, and the protein go through. Can the red blood cell go through? Do you understand? So if you know what is normal, then you know what is abnormal. So a patient with hematuria, and then she would say, 2 weeks ago I had sore throat. Would that be post-streptococcal glomerulonephritis? Would that be due to an immune response or immune complex response wherein the body attacks the antigen, but at the same time, the immune complex of combination of the antibody and the antigen, strep bacteria causing damage to the glomerulus, therefore leading to proteinuria, which means the protein now goes through. It was not supposed to go through. Remember, the albumin and globulin in the blood should remain in the blood because they're not waste. The red blood cell is also not waste. But just the same, because of the effect on the pores of the glomerulus, they will now go through and be able to be found in the urine. That makes sense to you guys? Okay? Is that clear? So, what else would you expect to find here? What happens to the BO and the creatinine levels if you are, can glomerulonephritis lead to renal failure? It could eventually, right? Do you understand? So, when you're dealing with this kind of conditions, you can see now what happens and what is it that we need to do. Okay? Is that clear? Are you able to understand what I'm trying to say here? Okay? Now, so hematuria is presence of blood in the urine. What is anuria? No urinary output. What is oliguria? Less than 30 ml of urine per hour. Some books would say less than 400 ml per day. Okay? When the blood passes through here, all the waste goes to the nephron. Do you know that in our body we have how many of these? 1 million nephrons per kidney. If you have 2 kidneys, how many total nephrons do we have? 2 million. That means you and I are multi-millionaires. We're rich people. Except the only thing that we're rich is nephrons, right? Now, do you realize that every time it goes here per day, we found out that in one day, 180 liters is formed as what? A filtrate. It goes here. Because there are 2 million of them. 2 million. Now, if this is formed, have you ever realized how much urine could possibly come out? 180 liters. Does anybody have a 1 liter of water container here? How many ml is that? You're not sure. Okay. How many ml is that?
700.
700. So can you imagine 1 liter of that multiplied by 180? Every day should have been coming out. But how come normally we only have 1.5 to 2 liters of urine per day that is being passed out as urine? So what did the kidney do with this water here? Reabsorb. Imagine water goes here, what happens? Goes back, goes back, goes back to the peritubular capillaries, right? Because why? Well, water is life. You and I, 66% of your body weight is what? Water. And most of its water is found what? Inside the cell or outside the cell? Because who needs the water? Therefore, it has to be more found inside the cell. So do you realize when you are out in the desert, you get lost, you can die within maybe 2 or 3 days without water? Food, you can last maybe for what? 5 days, 7 days? Water, a few days, maybe 2 days, 3 days. Because that's how important water is to the body. Okay? And water is found in the blood volume. So remember what I talked about last time, if you have polyuria, what happens to your blood pressure? It drops because your blood volume will also what? Drop. What happens when you have diarrhea? You lose water in your stool. What happens to the blood volume? It also goes down because now what should have been part of your blood plasma is now being excreted in the form of watery stools. You become what? Hypovolemia. Hypovolemic shock develops and you end up with dehydration, and of course it can lead to what? Renal failure too, and we'll talk about that in a short while. You understand? Now, so what is amazing here is that, can you imagine if you subtract 1.5 or 2 liters, that gives you 178.5, what happened to this amount of water in the initial filtrate of the 2 million nephrons? Practically all of these was what? Reabsorbed, went back to the blood. Can you imagine how efficient, therefore, our kidneys are? If you go into kidney failure, will I initiate dialysis? Have you heard of the word dialysis, right? The dialysis is basically an artificial kidney machine. It's a machine that will take over the function of the kidney. So what it simply does is that you give the blood to the machine, the blood will is cleaned and filtered by the machine, remove the waste, and the blood goes back to you with removing of the waste that we're talking about, the nitrogenous waste, right? Do you understand? Okay, how many of you have, I was an LVN here, does anybody work as an LVN in a dialysis center? Okay, I don't know if, I used to have people saying that some of them could actually work in LVN, okay? Do you understand the last? Okay, so let's now move on to renal failure, or what some would call it acute tubular necrosis, right? Okay. In ATN, there were stages. Can anybody tell me the first stage? Acute tubular necrosis, you have what? Prodromal, the next what? The oliguric phase, and then what's the third one? Huh? Post-oliguric, some of the books will probably say what? Diuretic phase, right? The idea, therefore, is in the prodromal phase, the urine output could still be normal or slightly decreased. But of course, when it becomes oliguric, like less than 30 ml, it's now in the oliguric phase. What happens now to your BUN? It starts to what? Creatinine and go up. It could still be normal here, but now it has to go up, right? It's the reason why what you often do, when you tell me the patient is oliguric, okay? Now, if you are oliguric, what does it mean? There is less what? Urine and water coming out. And patients develop what? Periorbital edema, bipiedal edema. What would that be an indication of? Is that fluid volume overload or fluid volume deficit? Because the kidney is retaining what? Water. Because it's failing. So what happens to the blood volume? It goes up. What happens to your blood pressure? It goes up because you're retaining water. You have bipedal edema or swelling of the feet because there's water retention. You have periorbital, orbit means eye, cavity. You have periorbital edema. Do you understand? What I'm trying to say, therefore, is every sign and symptom or clinical manifestation of a patient can be explained by what? This class, pathophysiology, and which is abnormal anatomy. If you know what is normal, then you know what is abnormal, and you can explain every single sign and symptom of your patient. For example, how come it's oliguric? Because the kidney is failing, right? You understand what I'm saying? Now, what about in the diuretic phase, or what we call the post-oliguric phase? You develop what? Increased diuresis. What would that be? Fluid volume overload or fluid volume deficit? Could be fluid volume deficit, right? You understand what I'm saying? Is it clear? When the body or the kidney is trying to compensate. Okay. Now, when we say tubular necrosis, tubules. Remember the word proximal tubule, distal tubule, Lupus necrosis means these tubules are dying or dead. From the word necrosis. Tissue necrosis means tissue death. Okay? And when the tissues are dead, can it lead to renal failure? Obviously it can. Because it's not able now to perform its function, which is to filter the blood. Does it make sense? So it's not just pure filtering of the blood, but maintaining fluid balance and making electrolyte balance with the sodium and all these other electrolytes, maintenance. Okay? Now, when you're dealing with acute renal failure. There are many possible causes. See? So let's write down in terms of, let me see, okay, do this first. So let's try to discuss these causes, right? So let me erase this. So you have either pre-renal, cause of renal failure, or acute renal failure, what else? Intrarenal, and what the third one? Post-renal. Okay? When you say pre-renal, so acute renal failure, you say pre-renal, what does it mean when you say pre? Before the kidney. Which means any problem that is found where? In the blood and in the renal artery. For example, if you have a blood clot here that is completely blocking the flow of blood in the renal artery, called renal artery thrombosis, can that lead to pre-renal acute renal failure? Why? Because what happens now? There's no more blood going to the kidney. Will the kidney die? What else can happen? What will the kidney filter when there's no blood going to it? Nothing. What is anuria? Zero urine output. It's even worse, right? Okay. What else? So A would be renal artery thrombosis. What about hypovolemia? What is hypovolemia? Decreased volume of blood due to many causes. Remember the possible causes of hypovolemic shock, such as what? Dehydration due to what? Diarrhea. Dehydration due to what? Vomiting. Dehydration due to what? Polyuria, just like in Addison's disease, right? Or diabetes mellitus or diabetes insipidus, where you have increased urinary output. What about when you're bleeding? Somebody stabbed you and you're bleeding and you lose a lot of blood. Will that lead to hypovolemia and hypovolemic shock? Will that be a possible cause of acute renal failure that is pre-renal? So remember these. Anything that affects the blood volume, causing it to go down, at the same time affecting the renal artery, causing artery thrombosis, then that is pre-renal, because pre means before the kidney. On the other hand, what is intrarenal? When there is actual what? Damage within the kidney. One of the more common causes of this would be what? The use of nephrotoxic drugs like your what? Aminoglycosides such as gentamicin or garamicin. The use of contrast materials where you have a reaction to this dye that are used for contrast medium studies. Right? Right? So nephrotoxic. Nephron means kidney, toxic means it's a drug, mostly antibiotics or materials that can cause damage to the kidney. What about your glomerulonephritis? Right? The same thing. Or nephrotic syndrome. But what happens in nephrotic syndrome is mostly what? What comes out? Mostly protein coming out, right? In nephrotic syndrome. Okay. Now what about post-renal? Post means after what? Kidney, which means kidney here, anything that affects the ureter, the bladder, and the urethra. Anything that will obstruct the flow of urine that is coming from the kidney. So like kidney stones, you call that what? Nephrolithiasis, from the word nephro, which means what? Kidney. Lithiasis, Lithiasis, means stone. Right? What's the most common stone that you would often see in these patients? Calcium oxalate stones. 4 years ago, I was driving on the freeway. I had severe pain in my left flank. What is flank? Lumbar. Left flank. Or we also refer to it as the left costovertebral angle. Why? Costo means rib, vertebral means spine. The angle formed between these ribs and the spine is called the costovertebral angle, or CVA. Flank pain, lumbar pain. What organ would you think that is being affected? The kidney. Aside from the fact that you can also have back pain due to other, like slip disc or what. But so when I had this pain, what I did was I had to what? Get out of the ramp on the 105 freeway, Lakewood. I called my wife and said, honey, I have so much pain in the left kidney. Of course, I didn't say kidney. I have so much back pain. I told my wife, can you pick me up in the gasoline station at Lakewood? And my wife said, no, just take the side streets and Imperial Heights. How can I say no? Yes, dear. So I was driving in the car. I was in severe pain. I think already developed scoliosis because of the pain. It took Imperial. Maybe by the time 30 minutes passed, I arrived in the house. My wife was waiting for me in the door. And when she saw me walking like this, oh, was it really that painful? I said, what do you think? So my wife brought me to the hospital. This time she was the one who drove. She had guilt feelings. Okay, are you okay, honey? I said, no. So we went inside the emergency room. They did a scan. And lo and behold, the kidney stone decided to, it became an accidental tourist. It traveled from the kidney land to Disneyland. You know, I live in Anaheim, right? Disneyland. So Disneyland, my goodness. It was taking one of those rides and it was so big. Oh shit! It's so small, I can't travel here. So the stone went down, it stretched my ureter, causing severe pain. I wanted to cry like a baby. All I could do was... Anyway, so when the scan was there, it showed that there was a kidney stone. Nothing they could do, so they said, okay, we just gave you pain meds. Tomorrow we can discharge you. Because the other kidney was okay, so my kidney function was okay. So they told me to see the urologist. The urologist is a special surgeon who does kidney, ureter, bladder surgery. So when I saw the surgeon, he said to me, and he knew that I had a medical background. I graduated from a medical school in the Philippines. And he goes, oh, Dr. Gama, what do you want? We can either remove it by doing a transurethral removal, or we can do it the natural way. I said, what's it? Of course, I knew what the natural way means. What he would let me drink 20 glasses of water a day, and then hopefully what more urine will push what the stone out, and that's what you call natural way. And I said, oh, like a baby coming out, right? My birth canal is my urethra. Now I know how painful it is. One week later, in medicine we call that EDC, or expected date of confinement. Normally it's about 9 months for women, right? Mine was a little bit shorter. I had a premature baby stone. It came out 1 week later. I felt so sad. I was alone in my labor delivery room, which was my bathroom actually. The toilet bowl was spanking clean. I made sure it was clean. Nobody was holding my hand. The Lamaze method of... My wife was at work, so I was by myself. I felt so sad. So I did this. There was a mirror in front of me. Forgot, I should have videotaped them. There was still no Instagram then, no Facebook Live. So all I could do was just... Finally, I could feel the baby stone coming out from my birth canal. This is where the vagina or where the urethra. The stone was crowning like this. And the stone, the baby came out. Wow, welcome, Daddy. I'll miss you. The stone spoke to me. But my God, the stone fell into the toilet bowl. Bang! I grabbed my baby stone, but there were no heartbeat, no respiration rate. The baby stone was dead. I tried to resuscitate with my finger. Despite heroic measures, I pronounced my baby stone dead at 9:30 a.m. on that particular day. A day that I can never forget because I just lost my baby stone. So we had to do a post-mortem autopsy. I brought my baby stone, still with tears in my eyes. I went to Kaiser and said, can you do an autopsy of my baby stone? And the results came the following day, and they said, your baby stone was calcium oxalate, And I said, okay, I will name him calcium oxalate Gamo. That is my last name. And I said to myself, goodbye, baby stone. So I buried my stone at the back of my house. So there is a big marker here. Here lies baby stone calcium Gamo oxalate. No, other way around, calcium oxalate. So there is one episode of my life that was so traumatic that I said to myself, from now on I will stop drinking what? Coke, and rather drink water, which I did for 1 week. After 1 week, I went back to Coke. Favorite drink, I call it cocaine, you know, Coke with sugar cane. I don't drink Pepsi Cola, I drink Coca-Cola cocaine because it contains sugar and keeps me awake at night when I have lectures from 6 to 11 p.m. So how many Coke bottles or cans can I drink in one day? Maybe 20. And that's probably the reason why Coke is getting richer and me getting poorer. But what can I do? And I would always rationalize and say, anyway, the Coke can has water in them. But I should be drinking water. Because how do I prevent the formation of a stone? By drinking a lot of what? So can dehydration be a risk factor to stone formation? So what happens if I don't drink water? Will I develop another stone 1 or 2 years from now? So if this was 4 years ago, OMG for Dr. G. I will be driving on the freeway again. Honey, I have kidney stones. And by then I may have a different honey, so we'll be more responsive. Say, don't worry, honey, I'll be there. I'll be there. I'll be there. No, I'm just joking. And this is so funny because, would you believe, a year ago, mine was 4 years ago, right? I received an emergency telephone call from my wife at 3 in the morning. I don't think he doesn't mind. I hope. Privacy rule, but it's okay. My wife said, can you come to the emergency room because she works at Cedar Sinai. I have so much pain, and she couldn't describe where the pain was. I thought it was appendicitis, right? Anyway, to cut the story short, I flew. I have a helicopter standby in my house. No, I'm just joking. I don't even have a... So I was there maybe in 14 minutes. There was no traffic from Anaheim to Cedar Sinai here. You know the Cedar Sinai. She's working there as a microbiologist. So she was actually working that night, the night shift. So at 2 in the morning, she felt this pain, a big stabbing pain. She didn't know what it was, and anyway, I saw her in the emergency room, and they found out that she also had what? I was smiling and said, see? You see how painful? She was crying on the phone when she was telling me to come. I said, what's wrong? I can't understand. So, and I said, okay, see? And mine was easy because I just had to deliver my baby stone through my vaginal urethra. They had to what? They had to get the stone for her. So I told her, see, now you feel what I felt 4 years ago. So now we have to keep on drinking water. Oh, no, actually, she has to drink water often, but me, just still cocaine. Coke with sugar cane. Okay? Now, what's the most common stone is calcium oxalate. What if your patient has gout? What kind of stones would you expect to find in the kidney? So you know uric acid crystals can deposit in the joints, causing the joints to become inflamed. It's called gouty arthritis. From the word arthro, joint, itis means inflamed, right? And can you just imagine if you were to break glass, uric acid crystals, like broken glass, put them down into your joint, can that be a source of pain? Now can that uric acid crystals develop into a stone inside the kidney? That's why it's called gouty nephropathy. Nephron means kidney, pathy means pathology. So the gout in the joints will not kill the patient, but it's actually what? The uric acid crystals, the gouty nephropathy will kill the patient with gout. Do you understand? Okay. I used to remember whenever I have patients like this with gout, it's always worsened or aggravated by drinking alcohol. I used to remember I had this patient who was a fiscal, a lawyer, and he was a very prominent lawyer where I used to practice in the Philippines, and he would call me and say, I'm on the way to the hospital because I need to be given some pain meds. I have to inject to him because it was very painful. That's how painful it is, okay? What about if you have an infection? What kind of kidney stones would you develop if it's due to an infection? Struvite stones, S-T-R-U-V-I-T-E, right? Struvite stones, okay? So it can lead to what? Post-renal obstruction, causing, it could, if this keeps on coming back, can I develop kidney failure eventually? Yes, okay? So I should do what I tell my patients to do. Drink a lot of water. There you go. Remind me, if you see me with a Coke bottle or tell me, Dr. Gama, remember, you promised to drink what?
Water.
Then I will put another water here. Bottle and Coke at the same time. Alternate. Okay, now, if you have kidney stones here, will the urine be able to go out? The urine containing water will go back. The water will make the kidney what? Enlarge. It's called hydronephrosis. Hydro, H-Y-D-R-O means water. Nephrosis means enlargement of the kidney as a result of what? Obstruction of the ureter due to presence of a kidney stone in the ureter. Okay? Is that clear? Okay. So, now I forgot to mention, we talked about these two diagnostic tests. BUN creatinine. There are a lot of them. One of them, of course, measurement of the GFR, or the glomerular filtration rate. Another one is the measurement of what we call creatinine clearance. What do you mean by the word to clear? To clean. To clean the blood. To clear the blood. To clear or clearance of the blood of the creatinine. By the way, which is more important? Which is, if you were to choose between urea and creatinine, which one is easier to perform as a diagnostic? Creatinine is better chosen. Okay, that's why in the diagnosis of kidney failure, especially chronic kidney, we look at the creatinine levels, right? Okay. Now, creatinine clearance simply means like this. We normally do what we call a 24-hour urine collection. So what are you going to collect? Urine this time. If I tell the nurse, start collecting at Monday, 7 a.m. up to Tuesday, 7 a.m. That's 24 hours. So you have to know this because it's commonly the nursing board exam. Let's say you're the nurse, you went to the hospital, you saw the patient at 7 a.m. of Monday. The patient has a Euro bag, and when you look at the Euro bag had 20 ml of urine. What are you going to do with the specimen? Are you going to discard that specimen or make that part of your collection of the 24-hour urine collection? Why would you discard it? Why? Yes?
It's not 7 a.m. yet, so it's...
No, remember I told you, you were there at 7 a.m. and you saw the 20...
The urine came out before 7 a.m.
Okay, that urine was formed before 7 a.m. My instruction to you was collect what is formed between 7 to 7. Therefore, you need to discard. You're absolutely right. On the other hand, the following day at 7 a.m., you went to the Euro bag. The Euro bag is there with 30 ml of urine. What do you do with 30 ml of urine? Collect or discard? Collect, because it was formed before 7 a.m. of Tuesday. It means it's part of the order of Dr. Gamo to collect 24-hour urine collection. Now, are we going to measure the amount of creatinine in the urine? Because the creatinine is supposed to go to the urine. Are we going to do a blood serum creatinine at 7 a.m. on Monday? Yes. Are we going also to do a serum creatinine on Tuesday? And compare the results, that there is a formula to come up with the creatinine clearance. Okay? Do you understand what I'm trying to say here? Okay. Other procedures like KUB, have you heard of the word KUB, X-ray? Kidney, ureter, and then what? Bladder. So this is just a plain X-ray. I forgot to mention this. Actually, a week before I had my pain here, I went to an outpatient department, okay, because I had hematuria. Can you have hematuria too when you have kidney stones?
Yeah.
Yes, you could. And then when they did a plain KUB, they saw the presence of a small white dot. It was still here, and there was still no pain. It was actually the original stone that I had, but which I probably ignored because I didn't really bother to think about it until I have what pain. Right? I should have seen already a nephrologist by then or a urologist by then, but I did not decide because I was busy working, supporting my family of a young family of 3. So, do you understand what I'm saying? Okay. So this is why it's very important to do this thing. Now, let's move on to, so we talked about this, right? So we talked about kidney stones, renal failure. We talked about the nephron, the role of the nephron, right? We talked about the stages of ATN. In the stages of chronic kidney disease or end-stage renal disease, there are a lot of possible ways of classifying them, right? One of them was using the nephron loss. How much of the nephron is lost? In your book, it says about renal or what? Decreased renal reserve, when the amount of nephron loss is what? Less than what? 70%, right? What about renal insufficiency? 70 to 90. What about if it's more than 90%? Nephron loss, damage to the nephron of the kidney. End-stage renal disease, that's called uremia, okay? So these are the people who normally undergo what? Regular dialysis or possibility of a possible kidney transplant. How many of you are willing to donate your kidneys if someone in the family needs a kidney? Let's say your mother needs a kidney. Would you be willing to give your kidney, Miss Javier? Why are you smiling as if you don't want to? I said, as if, no way, okay? Where's Amin? Are you willing to give your kidney to your mother? What about your father? No? You hate your father? You love your father?
I love it.
Both. Good for you. If only my kids were like that too. They love me, but Dad, I love you, but I cannot give you my kidney. Oh my God. It's their prerogative, right? But of course, you can donate. If you're willing to donate to other people, why not your parents, right? Or your brother or your sister who needs a kidney, right? Okay. So, nowadays, there are a lot of ways of even doing dialysis with peritoneal dialysis, which can be portable. And apparently, hopefully, time will come when we come up with our portable dialysis. I keep coming up with the idea of, remember these machines that they have there? They're so big, right? I make them portable, I put them at the back and sell them on Walmart. J. Gamo Foundation, Research Foundation will come up with this device. All you need to go to Walmart and say, hey, is that made by Dr. Gamo? Okay, I want that. I have kidney failure. I'm just joking. Hopefully one of these days. Okay? The bottom line, therefore, is that we don't have to make this Navita run out of business, because you now have a portable dialysis machine in your hand. Remember that? Okay. Now, the thing we need to know, therefore, is that okay, did we talk about this already? Oliguria, anuria, polyuria, hematuria. What is pyuria, by the way? Pass in the urine when you have what, an infection, right? Okay. When you have UTI, right? Okay. Proteinuria. What is nephralgia? Pain with kidney stones. Nephron means kidney, right? Okay. We talked about the nephron, the types of stones. I'm just going over the outline or guide for your quiz. We have prerenal, interrenal, ATN, okay, anemia. Anemia to chronic kidney disease is due to what? Lack of what substance? Because remember, the kidney is supposed to produce the erythropoietin, which is supposed to stimulate red blood cell production where? In the red bone marrow. Okay? The kidney produces the erythropoietin, which goes to the blood, goes to the bone marrow, letting the bone marrow is stimulated to produce more red blood cells, right? Therefore, if you lack erythropoietin because the kidney is failing, then you end up with anemia due to chronic kidney disease. Now, what do you think we give these patients? Synthetic form of erythropoietin, right? We talked about this before, right? Okay. Now, what is urethritis? Urethritis is nothing else but what? Inflammation and infection of the urethra. Common would be what? STD. Have you heard of STD? Of course, right? You're aware of STD. That's the reason why we always tell young people who are sexually active to practice safe sex, right? You always have to have what? What do you need to have with you all the time? Protection, such as what? What? Yes, Ms. Javier? A condom. How many of you have a condom right now? No one. So how can you protect yourself if you don't even have a condom? I'll give you a discount. I'm a businessman. When I was in med school, I used to sell chocolates now. I'm just joking, of course. Remember the most common in Walmart is Trojan? Trojan, right? Mine will be Gamogen. So I said to him, all I have to do is contact my friends from India and China, even though I don't have any friends, but I'll call them, I'm your friend now. All I have to do is repackage it and say, instead of Trojan, Gamogen. Okay. Guaranteed, you'll be safe, okay? If you wear it. So if you don't wear it, guess what? Now, the problem is this. A lot of these men, they know what is safe sex, right? They know the important role played by condoms. And the problem is that when women, unfortunately, the commercial sex workers, their customers want to have sex without the condom, who gets infected? The commercial sex worker, right? And it could be spread from one person to the other. What about the husbands? When they get infected because they had sex with a commercial sex worker, or otherwise known as prostitute, they get infected. Will they tell their wife, honey, I have gonorrhea? They will probably what? Not even say it to the wife. And the wife gets infected. Because that's a stupid husband, right? So they have to be treated both, right? Understand? I remember when I was still younger, you know, in the 80s, I was a medical intern in a big government hospital called the Philippine General Hospital. The husband would come to me for outpatient consultation, and they would say, can I speak to you in public, sir? I said, of course. And they would say, oh, this is what happened, I had this, blah, blah, blah. I paid this woman, we had sex in a hotel. And after 1 day, I started to have what? Penile discharge, right? And I said, okay. So we did the discharge. Of course, you can actually do a gram staining, and you can also study the studies of possible gonorrhea. And I said, you know what? We have to tell your wife because we have to treat your wife. Of course, that is how the fight can happen. And then, okay, sorry, honey, I will not do it again. And after 1 month, I'll do it again. The idea, therefore, is that be careful, right? Now, urethritis due to Nephron gonorrhea. The reason why we're concerned about this because if the woman gets pregnant and she has gonorrhea, will that affect the baby? And every time the baby comes out, the vagina is full of gonorrhea, the vagina. And the baby's, what happened to the eye? Infected. So the baby would say, what the heck, mommy? You got me infected with that gonorrhea of dad. Have you ever, don't you hear these babies talk when they come out?
Sure.
Yes, they do. They think. They have this, I have a mental telepathy with them. I can read their minds. If only the baby could speak, the baby would say, what the heck? Shit, Dad. Oh, I'm sorry, stool, Dad. Stool. It's your fault, Dad, if I become blind because of Nephron gonorrhea conjunctivitis. It's your fault, Dad. See? So be aware of that. Be careful. What else? So the most common now they say is not gonorrhea but chlamydia. CHLAMYDIA. Chlamydia trachomatis. TRACHOMATIS. Second, if this were a supporting class role, the main actor is chlamydia. Then you have what? Urea plasma. Urea with plasma. Okay. Urealyticum. And these are the what we call non-gonococcal urethritis, NGU. Remember? If it's GU, gonococcal urethritis. Non-gonococcal is your chlamydia and urea plasma. Right? This is for urethritis because if it's pyelonephritis and other kidney infections is what? E. coli. Remember? E. coli? Escherichia coli. Now, as a woman who's married to a man who is unfaithful, having sex with another person, commercial sex worker, how would you know that this partner of yours has gonorrhea? There will be penile what? Discharge. And I suggest you put a camera inside the bathroom and look at the facial expression of your husband when he's making pee-pee, wee-wee. And if he goes, what is dysuria? I'm just joking, by the way, okay? Don't put a camera there without consent. Honey, I'm putting a camera there because Dr. Gamo suggested that. I want to find out if you have dysuria, which is called painful urination, because if you are not faithful, I can tell, because you will be doing like this. Every time the urine will flow, there's going to be pain. See? Dysuria. So penile dysuria, think of STD, right? Urethritis. You understand? Now, okay, so we talked about that. Now, with regards to what is cystitis? Just can the infection in the urethra go to the bladder? Bladder infection? How do you know? Because when the patient comes to the clinic, holding onto the bladder, anterior pelvic area, right? And then we do the diagnostic test, treat with the antibiotics, right? Now, when you say in men, problems among the reproductive organs in men, right? Right? So men, remember, if this, one of the things we always talk about is the penile structure, right? If it's a penis like this, the urethra meatus is here. That's where the urine will flow, right? What happens if it's on the dorsal side? It's called what? Congenital anomaly. If the urethra goes like this, like a fountain of water or urine, it's called what? Episphagia. You have not seen a fountain of urine? Episphagia. Epi means on top, dorsum. What if it's ventral surface? Hypo means below. It used to water the plant. I'm just joking. Now, what about if you have men who suffer from persistent painful erection, priaphism, okay? Persistent painful erection. What is phimosis? When what? The prepuce cannot be retracted and you have a small opening at the end, right? Remember the prepuce or the foreskin is in patients or in people who circumcise, we cut and then what, you fold, right? But if it's uncircumcised, it might not become, it can narrow, it's called phimosis, right? Okay, is that clear to us? Now, what else? Of course, the lack of an erection. Remember? What causes an erection in men? Parasympathetic nerve, thereby what is ejaculation? Sympathetic, okay? So, remember, when a man reaches his point of no return, what is the point of no return? Climax, expert, that's the right word, climax. You're the only one who came up with the answer, everybody was so quiet. Ms. Javier, what is climax? Is it the point of no return? Is it also known as orgasm? Okay? So I always think of this, I always compare this to a symphony, like an orchestra, Beethoven or Mozart. Ching-ching, 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 spoke. And then ejaculation occurred, and then what goes up must come down. Spinning wheel. So what goes up must come down. Okay? Now, so remember this. When a man goes into power failure, of course, that's called impotence. You cannot have an erection. It's a big problem, right? So we don't go. We'll talk about that later. I'm going to ask you to discuss that. Okay? Now, so think about this. Now, what's one of the things that I realized in this world? Men can have an orgasm or climax maybe to now, at this very moment. When is the next time? Maybe a few hours later, or maybe the following day, right? What about women? What do they have? Multiple what? Yes, Miss Reyes? Multiple what? Orgasms, right? Life is not fair. I belong to the Me Too movement. Remember the Me Too movement? No, I'm not trying to make fun of that Me Too. I mean, sexual assault is bad, but I'm just voicing out it's not fair. When women can have multiple orgasms and men, OMG, for Dr. G and the rest of us men, we have to wait for another few hours before that erection will come back. Don't you like it, women? You can have multiple orgasms. I was watching this episode of, was it Grey's Anatomy a few years back? Did you watch that episode where this woman was brought to the emergency room, whereby, remember that? You remember the episode? The woman, this woman would have orgasms every 5 seconds or 10 seconds. So she was brought to the ER. She was lying down on the bed. This is actually an episode of American television, Grey's Anatomy. The woman was there, and this young, I think, virgin intern, the guy was like a male intern, maybe had not sex yet. He was so young and so naive looking. He was a curly hair. He was peeping at the woman. He was a medical intern, so he was a doctor. So Because maybe like me, I've never seen a woman with multiple orgasms. So this woman would just close her eyes, and just smile. And after 10 seconds, can you imagine if that person is teaching here and then I'm just joking, but how can you have a job, right? But I really feel bad that men have, not like women who have multiple orgasms, right? So I will create also my Me Too movement for all the men in this world, okay? It's a form of, it's not fair, right? It's not fair. Okay, now, we went into, what about, now remember the gonad, what's the male gonad? The testis, right? The testis in a developing fetus inside the mother's womb is initially as an abdominal pelvic organ, it should start to descend. If I'm not mistaken with my OB, it should start to descend in the 27th week of pregnancy, start to descend. By the time the baby is born, it should now already be inside what? The scrotal sac. What is the term called when there is failure of the testis to descend? Cryptorchidism. C-R-Y-P-T-O, orchidism. O-R-C-H-I-D-I-S-M. Cryptorchidism is therefore defined as the failure of the testis to descend into the scrotal sac. Why is there a need for the testis to descend into the scrotal sac? Because why? In the abdominal cavity, it is what? Pelvic cavity, it is what? Warm. If you do not allow the testis to descend, all the sperm will be dead. It will be boiled, like a boiled egg, you know. And your child becomes what? Sterile. Your future son becomes sterile, and you don't become a grandmother. So what do I tell mothers? This is just my personal advice from Dr. Gamo. When you delivered a baby boy, you are perspiring. Within the first hour of delivery, you go to the nursery, coochie, 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 grab the balls. Why are you laughing? Why are you concerned about that? Because you want to make sure that the testis has what? Descended. Now, why do you need to grab? Well, no, I'm not just kidding. Don't go to grab. It's called palpation. You palpate what? Because if you just look, it's good bulging, but it might just be filled with fluid. So you want to be sure. You want to find that solid testis there. Palpate. OMG, I can be a grandmother now. Okay, you understand what I'm saying? Now, what happens if that testis is not descending and remains there? There are two things that can happen. Of course, I already mentioned the fact that the baby boy becomes sterile. Second is that they could develop testicular cancer, which is life-threatening, could kill your baby. So please follow my advice. From now on, if you happen to be pregnant, oh, I remember Dr. Gao telling me, and you say, will the pediatrician not be able to check, or the nurse not be able to? What if they don't? They have other things to do. You understand what I'm saying? Or some people would even realize, hey, one of my testes that's descended, one is not there. I'm not sure. Some people are like that, right? Do you understand? Now, so that's cryptorchidism, right? Okay. Okay, so, and of course, prostate cancer and malignancy. And this, if the prostate gland is enlarged, can that affect the urinary flow? Yes, because it will cause obstruction in the prostatic urethra, right? Here. So why do we do a digital rectal exam? Because if you put your fingers inside the rectum, the prostate can be palpated. It's very near, right? Like this, to the urethra, the rectum. So we do a digital rectal exam to determine whether the prostate gland is enlarged or not, right? Okay, is that clear? Now, of course, cancer of the prostate easily metastasizes to the spine, very commonly seen. Now, women, what is in women? Okay, remember, in women you have the uterus. What is this? Fallopian tube with the fibra, fallopian tube, uterus, fundus, body, and then what? Cervix. It's like my lips, you know, cervix. And this is the vagina below, right? Okay. So what happens in women? Normally in a 28-day cycle, 28 days, right? 7 days a week times 4 is 28 days. You always count from the first day of menstrual bleeding, right? Let's say, what is the often average day? For 4 to 5 days of menstrual bleeding? I don't know, I've never had any menstrual flow, so. Let's say October 1 to October 30 or 31. Now what happens is that the first 5 days is the bleeding days. You count 14 days later. October 1 plus 14, October 15, you would expect the woman to ovulate. What is ovulation? Release of an egg. Okay, and if you have sex that day, within the next 2 days, 3 days, you could become pregnant, right? That's the date when you say they're fertile, right? Okay. Question now is, how do you know the woman is ovulating? There is a rise in the basal body temperature by what? 1 degree Celsius. For those of you, therefore, who have been married for 5 years and still do not have kids, why? Because it should require proper timing. You should time your sex with your partner when she is ovulating, right? So, what do you need to do? When you come to my class next week, you bring yourself with a thermometer. So by the time it's 8:30 in the morning and you check your body temperature, oh shit, Dr. Gamo, I have a rise by 1 degree Celsius. I've been married to this husband of mine for 5, we have no kids. And I said, okay, I have excused you, I have reserved a room for you. Your husband is waiting. Courtesy of the Jamie Camel Foundation for pregnant women. No, I'm not kidding. You have to have a basal body temperature with the use of a thermometer, okay? Now, when this occurs, you have sex, you got pregnant. Remember the safe and unsafe period? So you had sex on the unsafe, you become pregnant. Now what happens is that, what will the progesterone levels go? They go up. Why? Because what does the progesterone hormone do? Makes the wall of the endometrium, remember the lining of the uterus, become thicker, filled with blood, because that is where the fertilized egg will implant and grow the baby, right? The fetus. So that's we have to thickness. Now what happens if you do not get pregnant? What happens to the progesterone levels? They start to decline and go down. So if you decline of the progesterone levels, will there be hormonal support to the thick wall? The wall will die, undergoes necrosis. Part of it will slough off, S-L-O-U-G-H, which means your endometrial uterine lining wall will actually come out with the blood. That means a woman who is having menstrual bleeding, it is not just blood coming out, but part of what? The uterine wall coming out, right? I do not know what it is, but I'm telling you what it is, right? Okay? Is that clear? Now, what is the term when you say without menstrual flow? Amenorrhea. What about if there's painful menstrual flow or menstrual cramps? Dysmenorrhea. Okay, what is menorrhagia? Heavy flow within the normal menstrual cycle of 28 days. What about metrorrhagia? Heavy flow but in between irregular cycles, right? You understand what I'm saying? Okay. So be aware of these. Now, what is endometriosis? What is endometriosis? Endometrium, which means what? Remember when you are having menstrual flow, right? The endometrial wall was supposed to slough off, right? But some of them may end up what? Instead of going out, they will go back here. What? Go up here and then what? Spill into the pelvic cavity. You end up with what? Presence of the abnormal location of this endometrium. Can that be a source of pain eventually? Like dysmenorrhea and painful cramps? Yes. So that is endometriosis. Okay? Now, what else? Uterine prolapse. Remember, we talked about this before. What supports the uterus? The pelvic floor muscles, right? And that's why when women have 8 or 10 kids, every time the baby comes out like this, in the birth canal, 1, 8, 9, 10, what happens? The pelvic floor muscle becomes weak. And then is it possible for the uterus to come out? Yes, right? Uterine prolapse, or partial prolapse, or full. Okay? So that's the reason why when you're pregnant, what kind of exercise do we recommend women do? Kegel exercise, right? K-E-G-E-L. Kegel exercise are recommended, right? Okay, what else? What is PID? PID, or pelvic inflammatory disease, is nothing else but you have a infection in the urethra, can it ascend to the bladder, and that can, can it go into the urethra and it can affect your what? Vagina? I'm thinking of the other way. When you have vaginitis, can that become infection of the bladder, of the uterus? And then can the infection go to the fallopian tube, salpingitis? And that organism. So again, let's review. I don't want it to be confused with urinary tract and reproductive tracts. If a woman has STD or infection of the vagina, can it go into the cervix, cervicitis, then uterus infection, and then salpingitis or fallopian tube infection, and then can this organism be spread into the pelvic cavity? You will end up with pelvic inflammatory disease, right? Okay? Is that clear, class? Okay? And of course, we talk about cervical cancer. What's the most diagnostic common to perform? Your what? Pap smear, right? Papa Nicolau smear or pap smear. And of course, what's the difference between placenta previa and placenta abruptio placenta? In placenta previa, it is what?
Covering
The placement of the placenta is low instead of high, which is not good because there could be vaginal bleeding. On the other, what's abruptio placenta? Premature what? Separation, and the baby could die because there's no more oxygen to the baby inside the mother's womb. These are all life-threatening conditions. Okay, we've covered everything. I will give you a short 5-minute break. You can go and then come back, okay?